Well, hello there, everyone, and welcome. On behalf of Abbott, we want to thank you for taking time to attend today's program. This is Net Prolongation of Life with the HeartMate 3 LVAD, presented by Dr. Francis Pagani and Dr. Katherine Wood. More on their backgrounds in just a moment. First, I'd like to talk about the platform here today. Across the bottom, you'll see several widgets that you can move about to customize your view. We do suggest that you close other programs or browsers that may be running in the background, especially if they're connected to any type of audio or video. Chrome is our preferred platform for this event. There is a help widget at the bottom that you can click on if you do have any technical issues. I'll tell you that refreshing the screen, that will solve most of those issues and get you reconnected should there be any lag or delay for you. That's also where you see the Q&A module, and we encourage you to submit questions at any time during the presentation. Carved out a little time towards the end to address those questions, but please feel free to submit those at any time. We'll get to as many questions as we can. If we don't get to all of the questions submitted, we'll try to respond offline. With that, I'd also like to share some disclaimers with this audience before we get on to the content. The content in this presentation does represent the beliefs of the speakers and not necessarily reflecting the views of Abbott. Information presented is consistent with applicable FDA guidelines. This content reflects the speaker's experience. The applicability of this experience should be considered in the context of your individual centers and patients' needs. The speakers are presenting at the request and behalf of Abbott. Honoraria is being provided. This meeting is not intended for any CEU credits, and again, support for the program is provided by Abbott. I would like to introduce both of our speakers here today. Dr. Francis Pagani is with us, professor in cardiac surgery at the University of Michigan Medical Center. His clinical focus includes surgical therapies for advanced heart failure, including heart transplantation and mechanical circulatory support. And also on board with us, we're pleased to have Dr. Katherine Wood here today. Dr. Wood is the surgical director of LVAD program and a cardiothoracic surgeon at the RWJ Barnabas Health Northern Department, Newark Beth Israel Medical Center. Dr. Wood specializes in adult congenital and heart failure. So we appreciate both of them being on board for this presentation. Again, folks, the Q&A module at the bottom of the screen. There are also some resources. I'll address those a bit later in the program, but there's some resources where you can get some more information. With that, I want to turn things over to Dr. Pagani, a brief review of the agenda and really dive into the information. Dr. Pagani, the floor is yours.
Thank you very much. And it's a real pleasure to be here today. And I would like to thank Abbott for the invitation to discuss LVAD therapy for our patients. It's an important topic. I think it's a topic that needs a review of some of the important, I think, highlights that have developed over the past year or so. And I think it's a therapy that brings a significant benefit to our patients, but I think is underutilized. And I would like to explore some of those reasons and maybe dispel some of the biases that might be present against this therapy. But starting with that, we'll begin with the presentation. One, we know LVAD therapy is very effective in the treatment of heart failure. Heart failure is very prevalent, and it's mortal. We know that after a diagnosis, that a majority of patients will die within 5 years after presentation. And it's important that as more patients present with advanced stages of heart failure, we need to utilize therapies that we feel are really important to their benefit. One of the important realizations, though, is that a significant proportion of patients with advanced heart failure are not being referred for durable LVAD therapy, despite growing numbers of patients with advanced heart failure. If we look at data from the INTERMACS, the national database, we could see that the number of patients who have received a durable implant over the last several years has really remained flat with no increase. And this is despite the increasing numbers of our patients who present with advanced heart failure. If we look at the total number of transplants, we've seen that great strides have been made with heart transplantation in the last decade, and important increases in annual implant volume or annual number of heart transplants performed have been completed each year. I'd like to note, though, over the last year, in 2024, the incremental growth in heart transplants has plateaued. Now, whether this is just a single year observation or something more significant remains to be seen. Has this represented a saturation of what we could offer in terms of the number of annual implants per center per year? Does this have to do with more donor restrictions? Could we overcome this plateau with more use of DCC donors or other strategies that could help transplantation? We'll have to see how that evolves with time, but it is concerned that for the first time in over a decade now, we've seen an important plateau in the number of transplants that were performed in the last year. And so this raises the question: is as if more patients present with heart failure, what are our alternatives? If you look at the cumulative number of patients that we're treating, those with heart transplantation and those with durable LVAD therapy, the gains that we've made for total treatment have really been made with respect to heart transplantation. And largely, most of those gains in heart transplantation have been due to the recent use of DCD donors. I think one of the important considerations in heart transplantation is that we generally compare heart transplantation to durable LVAD therapy, with time zero being the point of heart transplantation. One of the things that this creates is what we call an immortal time bias, and we forget all the events that happened prior to the heart transplant procedure. And when one looks at a strategy of heart transplantation compared to durable LVAD, one must consider all the events that occur from the point of listing to the point of heart transplantation. And in the most recent data from UNOS, we see that after a period of 3 years, only approximately, just roughly under 80% of patients actually obtain a transplant. Nearly 20% of patients are either removed or died while waiting for a transplant. And this represents a significant number of patients that are listed. Alternatively, could these patients been treated with a durable LVAD? More importantly, are there other patient populations that could be treated with durable LVADs to help improve overall survival? I think one of the statements clearly is all advanced heart failure cannot be treated with heart transplantation. And with that, we understand that we need to move or promote LVAD therapy as a potential alternative treatment for advanced heart failure. Most patients receiving durable LVAD therapy today are receiving it primarily as destination therapy for patients who do not qualify for heart transplantation. And looking at the recent data from the Intermex, a large percentage of patients now are receiving temporary mechanical circulatory support as a bridge to durable LVAD support. If you look at that specific population, a larger percentage of those population were actually bridged to transplant candidates, suggesting that those patients that are receiving bridged durable LVAD therapies today are patients who have failed a strategy of temporary mechanical circulatory support. I think we could potentially identify those populations of patients that are unlikely to receive a transplant and provide earlier LVAD therapy to promote better outcomes. Just to review, the current indications for durable mechanical circulatory support represent patients with systolic advanced heart failure with New York Class Heart Association's Class 4 symptoms who are dependent on inotropes or temporary MCS. Additionally, there is an indication for patients who have significant symptoms and have failed GDMT. There seems to be a paradox between referral for durable LVAD therapy and current LVAD outcomes. With the current device technology, with some totally magnetically levitated centrifugal pumps, we're achieving the best outcomes we've ever achieved with durable LVAD support. In a recent review of outcomes by Tedford and colleagues in the Journal of American College Cardiology, we note that durable LVAD survival is now achieving a median survival that is greater than 5 years, with significant and sustained functional improvements and also significant improvements in health-related quality of life across all age groups. Improvements in survival have been documented through data for the Momentum trial. We see that looking at the total composite endpoints, including device exchange, disabling stroke, and survival, the HeartMate 3 outperforms the HeartMate 2 and significantly at 5 years. And even with just overall survival, the HeartMate 3 outperforms the HeartMate 2 pump with median survival clearly greater than 5 years. Trial data has been documented in the real-world experience from the INTERMAX database, and these are data from Jordi et al. From the INTERMAX annual report, where the most recent 5-year data suggests that even in a real-world population, a median survival now exceeds 5 years. Importantly, this observation extends across all age groups, even for patients 70 years of age and older now. Median survival is approximately 5 years, which is exceptional given the degree of survival for these patients who would not have this opportunity with durable LVAD support. In general, contemporary LVAD support has been demonstrated significant improvements in hemocompatibility. There's been essentially elimination of pump thrombosis. The risk of stroke now is near that of someone with a patient with class 4 heart failures and atrial fibrillation. In a recent report by Molina and al. Out of the INTERMAX, in a follow-up of nearly 7,000 patients with a median follow-up of 11 months, the risk of stroke was 5.9%. And importantly, nearly 50% of those strokes occurred within 7 days of pump implant, and 70% of those strokes occurred within 2 days of implant, suggesting that the majority of strokes are procedurally related and not pump related. And I think this gives us an opportunity to improve implant techniques and reduce the risk of stroke, but does demonstrate that the technology of durable centrifugal pumps with magnetic levitation is a reliable in terms of hemocompatibility. There was also recent improvements in decrease in non-surgical bleeding, and important advances in the ARES trial has reduced non-surgical GI bleeding. There are opportunities to improve provider and patient acceptance for greater adoption of durable LVAD therapy. I think this is a summary of what we have achieved over the past 3 decades. There's been really largely the improvements that we've seen in survival and reduction in adverse events have been due to improvement in technology. And I think going forward, the biggest improvements we're going to see is continuing development of technology. And I'd advocate that we need to continue our research in bringing new technology to market. I also think there's opportunities to address the ambulatory population. We have moved with the change in allocation, in the heart transplant allocation system, we have moved largely to treating shock. While that has improved the outcomes for patients with shock, I think we are ignoring the larger population of patients with ambulatory heart failure who are not being offered an opportunity for LVAD therapy in a more timely fashion. And I think this represents the biggest area of potential growth for utilization of durable LVAD therapy that can have a significant overall benefit for patients with advanced heart failure. So I think there are a number of opportunities to improve provider and patient acceptance for greater adoption. I think part of what we see today is education, educating our providers and patients about the outcomes, contemporary outcomes with durable LVAD. I think there are improvement in management, and I think that you can see through ARES trial, where we've now learned that aspirin is no longer necessary for antiplatelet therapy during LVAD support, and innovation. And I think it's important that we see modifications to our pump designs and newer pump designs being brought to clinical use. At that point, I'll turn it over to our next speaker, Dr. Wood.
Thank you, Dr. Pagani. And thank you to Abbott for this opportunity as well. And thank you to all of the audience for joining today. So I just want to highlight again the outstanding one-year outcomes that Dr. Pagani shared from the 2023 annual STS Intermax report. This inspired a deeper look into this data in the 2024 annual report led by Dr. Meyer and Dr. Canmore. In this data set, we see that we still have very excellent survival in the age group less than 50, and we continue to see improvement in adverse events after LVAD. The improved hemocompatibility profile of the maglev device, as well as improving outcomes, supports consideration of LVAD as a strategy to achieve net prolongation of life. And I want to stress that this is net prolongation of quality life, not just quantity life. We have several data-heavy slides to get through to help us better understand the differences in the data currently available from our national registries. And it is important to understand that these data are not linked between mechanical support and transplants, nor do they collect the same data points, which makes it challenging to do direct comparisons. However, we do consider all of this in the context of our patients' goals to inform clinical decisions and recommendations. This is the similar slide to before, but this is the 2024 report, which again shows almost 92% survival at 1 year in the age group less than 50. And again, we still have outstanding survival amongst all groups. We continue to see improvement in the incidence of GI bleed for all patients, with 83% freedom from bleeding in the less than 50 age group at 1 year. Dr. Pagani, could you share some of the data in recent trials that have impacted our management as we anticipate this event to continue to improve?
Yes, in relation to GI bleeding, the results of the ARES trial show a 6% improvement in event-free survival with non-aspirin use, and aspirin avoidance was associated with reduced non-surgical bleeding and overall reduction in GI bleeding. So these are important findings from the ARES trial. There are other potential trials looking at other vitamin K antagonists and other alternatives to vitamin K antagonists that are being considered in the near future for anticoagulation management.
Great. Thank you so much, Dr. Pagani. So Dr. Pagani also shared some details about stroke, which I'll show a little bit more in the next slides. But again, just as a reminder, in the current era with the maglev device, we again are seeing significant improvement in stroke outcomes with less than 7% in the first year and less than 6% in the less than 50 age group. In a subsequent analysis that was performed by Dr. Molina and colleagues, we see 50% of stroke occurs within the first week after LVAD implantation. And as expected in the Kaplan-Meier curve, we see significantly worse survival for those patients who develop an early stroke. Of the 50% of strokes, as Dr. Pagani mentioned, that occur in the first 7 days after LVAD, 70% of these are actually occurring by post-op day 2. And as he highlighted, this is an incredible opportunity for us to modify how we are caring for and operating on these patients in order to improve these outcomes. The highest risk for these patients was with a left atrial appendage thrombus that was not removed at the time of implant. But the next highest risk is actually combined therapy of temporary mechanical support, followed by ECMO alone, followed by temporary LVAD. And this is really important data as we consider a strategy for net prolongation of life. While there are inherent patient factors that we can't change, we do have this opportunity to impact the risk of stroke associated with temporary MCS bridging. We can encourage earlier referral, earlier surgical intervention before end-stage heart failure patients require additional support. Unfortunately, we continue to struggle with time to MCS infections. As we know, this is an outcome that we continue to work on as a field and continue to try to standardize wound care and driveline dressing care. But it's likely not to significantly improve until we can remove the driveline. I do want to highlight here that while we capture the incidence of MCS infections in the Intermax registry, this doesn't represent the severity of infection or long-term outcomes or consequence to the patient. And then furthermore, the SRTR annual report does not report infection or hospitalizations related to infection that would allow for real comparison of this data set. And then as mentioned earlier, the excellent maglev pump, we have significantly improved outcomes related to device malfunction with less than 3% of patients affected within the first year after implant. This slide is demonstrating the LVAD survival for patients less than 50, by BMI. And if you look here at the blue line are patients with a BMI less than 30, and then the red line are a BMI of 30 to 45. And I really want to highlight these outcomes within the first year. BMI less than 30 has a 93.3% survival, and then 91.2 for the obese patients. And this is important because when we look at patients who are currently waiting on the transplant list, we have the yellow line here indicating the patients who have a BMI of 30 to just under 35, and approximately 30% of our wait lists are patients who are obese. And this is factors into waitlist considerations and strategy for bridging. So since the 2018 allocation change, heart transplant candidates are more likely to be listed with temporary mechanical support. And Dr. Norden and colleagues evaluated the impact of blood type and body size on successful bridging to transplant using temporary support. Box A is showing patients who have a blood type O and looks at temporary support being an Impella 5.0 or 5.5 or a balloon pump versus durable LVAD as the bridging strategy. Their findings in blood type O patients demonstrate improved survival in the durable LVAD group. In further analysis, stratifying these blood type O patients by body size, we see that obese patients have a lower probability of survival if bridged with temporary MCS. The final recommendation from the authors is to consider targeted bridging strategies based on these patient factors. There are several reports now that demonstrate prolonged waitlisting for blood type O patients, in addition to worse outcomes for patients who are waitlisted for more than 7 days on ECMO. These data continue to support the increased risk of patients who have a prolonged waitlisting period. And in review of the SRTR annual report, we do see a decrease in waitlist mortality since the 2018 allocation change. However, that is still hovering around 8 to 10%. And additionally, close to 15% of patients who are removed from the waitlist die within the first 6 months. We also see increased incidence of acute rejection ranging between 20 to 30% for patients who are less than 50 years of age. And although this report does not delineate between antibody-mediated or cellular-mediated rejection, this may translate to increased graft vasculopathy in these younger patients. And unfortunately, cardiac allograft vasculopathy remains very common, with 30% of patients affected by 5 years post-transplant and about 50% affected at 10 years. If requiring relisting, these patients have increased waitlist mortality when listed as status 4. And of transplanted patients in the 2023 annual report, 14% were status 4, and less than 3% of patients actually end up being retransplanted. We do have excellent outcomes that have continued to improve over time in transplant survival, where we're near 80%, or actually at 80% for all comers, and excellent outcomes at that 1 year survival over 90%. And it's important, though, to note that these patients who are status 1 have slightly reduced survival, which is not terribly unexpected given the acuity of their illness. However, these are opportunities that we have to consider a different strategy. And when we look at transplant survival after VAD, it's actually very comparable to transplant survival overall in that previous slide, near 80%. And I want to highlight a paper that was recently published by Hong and team, and they found that DCD transplant after LVAD, not unexpectedly in their overall results, demonstrated that there was increased mortality in the patients who had an LVAD first. However, on further investigation and stratification, they looked at each type of durable VAD, being the HeartMate 2, the HeartMate 3, and then the HeartWare. And it was very interesting to find that 1-year survival after a HeartMate 3 to transplant is still at 91%. And again, looking at this data, we see that durable VAD listing status as status 4 still has a 1-year survival of 91%. So these are really excellent outcomes in the patients who have a VAD first and then go on to transplant. And then there's the question about potential for recovery. As we've discussed, there's a lot more patients who are moving to temporary mechanical support very early and an early strategy of transplanting these patients. And we have to ask the question if any of these patients possibly would have recovered. Dr. Drakos and Dr. Kanwar gave an outstanding webinar 2 weeks ago. There's a QR code here you can see. And if you haven't seen it, I really, really recommend watching it. During this presentation, they, of course, outlined the patients who could be candidates, as well as risk models to facilitate these conversations with patients and decision-making. Understanding the improvement we've had in GDMT over time, and then the ability to build a structured process or a program really seeking myocardial recovery, allowing us to continuously evaluate and optimize these patients after VAD implantation. Conservative estimates of 10 to 15% of patients may be eligible for recovery. And as we all know, as much as we cardiac surgeons really love doing heart surgery, at the end of the day, any patient who gets to live with their native heart is going to be better for it as long as they can tolerate it. It is unclear the long-term impact of the 2018 allocation changes on this opportunity for recovery, and obviously we'll be very interested to follow that data as it comes out. One thing to note, the QR code, this will take you to the link to request the access. I believe the posting of the actual video is coming soon. So when we start talking about net prolongation of life, the overall considerations, and this is really a summary slide of all the data we just reviewed. For LVADs, we have 92% survival at 1 year in patients less than 50, 73% survival at 5 years in patients less than 50, 10 to 15% incidence of recovery, a 7% risk of stroke in the first year. On that on. Okay. And a less than 2% risk of stroke in 3 to 5 years. Or sorry, a less than 2% risk of stroke in years 3 to 5 post. It looks like my slides are stuck. Janelle, I might see if you can forward them.
And I'm going through, Doctor, here a couple. There are a few more transplants. I'm going to go through the whole list and bring those up if you'd like to address those.
Yep, that's perfect. Thank you. So for transplant outcomes, we have a 91.5% survival at 1 year. And again, I want to highlight that we just saw that slide for a VAD to transplant. A HeartMate 3 to transplant had a 91% survival at 1 year. An 8.5% waitlist mortality. And status 4 transplants only account for about 14% of all transplants. There's a 20 to 30% acute rejection for patients less than 50, and a less than 3% patients are receiving a repeat transplant. Dr. Pagani, I was wondering if you wanted to speak at all to this as well, and comment on your perspective.
Okay, we have some case presentations I think could highlight some of the issues, but I think one is we're seeing very good long-term results, and many centers now have a number of people on for support for 10 years, and it really brings the question up, particularly for young patients in their 20s or 30s. When we look at overall, is a strategy of a delayed bridge, meaning 5 or 10 years to a transplant, increase your overall life expectancy, given that retransplantation is the risk of the probability of obtaining a retransplantation appears low based on current data. So these are things to consider. I think the current allocation system does not really allow us, or it penalizes strategies to try to recover the heart. With the use of temporary devices or even durable devices, both device types are penalized with current allocation schemes. And so I think we need to be more creative in how we could amend the allocation processes to allow the use of both temporary and durable devices to try to maximize recovery of native heart, or actually allow patients to stay on a durable LVAD for a period of time before receiving a transplant, but prioritizing the need for a transplant at the time after spending a certain time on device. I think there are a number of changes to the allocation systems that could promote that type of strategy, and I think I would encourage that even more types of amendments to the allocation system be considered to try to promote the use of both temporary and durable devices to recover the native heart.
Thanks, Dr. Pagani. So in summary, we'll review just some thoughts and ideas about a strategy for net prolongation of life. I had one of my mentors tell me this, which almost doesn't even need to be repeated, but less sick patients are less sick. They do better perioperatively. And we all instinctively know this, and we all see this. So moving the needle on when we get these patients to the operating room certainly will be of benefit. We recommend any patients who have a predicted long wait time or have temporary mechanical support for more than 2 to 4 weeks, and they are a candidate for an LVAD, could be considered for net prolongation of life with an LVAD upfront strategy. Blood type O patients and obese patients, as we mentioned earlier. And key considerations as we talk about this, it really is about shared decision-making with the patient, arming them with the same information that we have, and allowing them to make an informed decision to the best of our abilities with the data that we have, understanding we don't really know the long-term, 10-year results of decisions we make today. Patients who have an expressed desire to extend their life more than 15 years should be considered for an LVAD as an upfront strategy. Obviously, patients who are less than 50 years of age would benefit from this and have excellent outcomes with LVAD. Patients who are 50 to 65 years of age also have excellent outcomes with LVAD. And again, if they're expressing a interest in living more than 15 years, this would be a great strategy for them as well. Anyone with end organ dysfunction that's anticipated to improve with VAD and unloading, it'll make them a better transplant candidate in the future and hopefully demonstrate improved long-term survival once they receive their transplant. Adult congenital patients who may benefit from unloading potentially remodeling lung and liver, reducing their risk for needing a multi-organ transplant. In addition, for patients who have a high risk for sternal reentry, consider a thoracotomy approach to save them on one more sternotomy before they may get a transplant down the road. Considering potential for myocardial recovery should be an upfront discussion for every patient who might benefit from this strategy, and we can decommission or remove the LVAD at a later date if necessary. And then just the general idea of prepare now to plan for the future. We know that what we have in heart failure patients in our therapeutic options at present are palliation, and we want to try to get combined therapies to allow the patients to live the fullest life possible. So if we prepare now for that, do an excellent LVAD surgery, reduce their risk of infection, reduce their risk of complications perioperatively, consider doing a thoracotomy approach to set you up for success for the transplant down the road and reduce the risk of sternal reentry. All of these are opportunities that we have to continue to optimize patients and their outcomes. So now we are moving into some clinical case studies, but I do have just a couple of questions in the QA box. I could spend a couple of minutes looking at these real fast. Dr. Pagani, I'm going to pass one to you. We have a comment that considering current UNOS allocation system and long wait time for blood type O on LVAD, do you suggest using an LVAD for net prolongation of life or try temporary MCS for transplant, as getting an LVAD may mean a long wait time for heart transplant?
And Dr. Pagani, I'll maybe suggest just double checking that mute functionality. We're not hearing you right now in that answer.
Yeah, so considering current UNOS allocation system and long wait time for a blood type O, do you suggest using LVAD for net prolongation or try temporary MCS for heart transplantation? Well, again, this depends on center, and because it also depends on a number of factors. One, whether a center is comfortable using DCD donors or uses DCD donors routinely as a way of obtaining donor organs for more difficult patients to transplant. But overall, particularly in a large patient that has a prolonged waiting time, durable LVADs could potentially offer a period of weight loss, a strategy of weight loss, and other ways to reduce other risk factors or comorbidities to the transplant. And if one considers now the potential changes to the allocation system that are going to potentially prioritize patients who've been waiting for longer periods of time on a durable LVAD, then this strategy I think would make more sense. But again, whether one chooses to go straight to transplant with temporary device or a durable device as an alternative strategy really depends with the center's philosophy in terms of ways of acquiring donor organs, utilizing Hep C positive donors, DCD donors, use of different procurement strategies the such that could facilitate obtaining an organ.
Thanks, Dr. Pagani. I'm going to move on to a very quick clinical case presentations, and then we'll have some more time for conversation here at the end. This is actually a report from Dr. Schmitto, just actually published, I want to say 1 or 2 months ago, in this past 1 or 2 months in GHLT, reporting the 10-year outcome of the very first HeartMate 3 LVAD implantation. And I share this because I think it's important to contextualize it. Again, we still don't have true long-term data on this pump looking out at 10 years. And We also, the more we know, the more experience we have seen a trend in improved outcomes over time regarding any type of the adverse events associated with it. So this is a 55-year-old gentleman with dilated cardiomyopathy who underwent a HeartMate 3 in 2014. His INR goal was 2 to 2.5, or has been 2 to 2.5, and he received aspirin. He did have a positive swab on his driveline, but no clinical signs of infection, so this was never treated, and essentially had a very stable life, uncomplicated, uneventful course, routine follow-up for the first 6 years. He developed the external outflow graft obstruction and underwent surgical decompression in 2020. That's the only surgical intervention the gentleman has had. He does have some aortic insufficiency, but does not currently require any intervention. And he has had some modular driveline exchanges due to damage of that silicone layer. And what I think is maybe the best part of the story, and something that we don't actually have a lot of data on in our field right now, is that he's very happy with his device. He has, as he states, an excellent quality of life. So he's currently 66, NYHA Class 1, and he's declining heart transplant listing because he has an excellent quality of life. Dr. Pagani, I'll send it back to you for the case study.
Thank you. And then we have one more example of a case study that I think is potentially reinforces some of the issues that we talked today. You know, 28-year-old male who presents with new onset acute systolic heart failure, no prior history of heart failure, complicated by cardiogenic shock, average size person, echocardiogram, typical features of acute cardiogenic shock. Right heart numbers are consistent with that. Normal coronary anatomy is suggestive of a non-ischemic cardiomyopathy, some mild organ dysfunction. And typically, there are, the obvious strategies to try to treat or resolve this situation would be inotropes and transition to oral GDMT with complete recovery or partial recovery. And that would be an optimal goal. Potentially the second line treatment would be inotrope therapy, if unresponsive to inotrope therapy, to utilize temporary MCS, and that could more commonly now include a intra-aortic balloon pump, or now a high flow type of microaxially pump, typically an Impella 5.5, with some transition, if successfully, to oral GDMT and recovery. If that were to fail, then what are the alternatives? One might then transition immediately to a heart transplant, or alternatively, do you transition to a durable LVAD with GDMT? This particular patient with an acute onset of heart failure has never seen GDMT therapy, and really it might benefit significantly from GDMT therapy for its heart failure. And if you look at the ICARS model of potential recovery with durable LVAD therapy, this patient would have approximately a 39 or nearly 40% chance of recovery with durable LVAD support. So one, could you place an LVAD and achieve durable support over several achieve durable support and recovery over several months? Or alternatively, could you, if recovery did not occur, have a prolonged bridge where the patient stays on durable support for a number of years as a bridge to heart transplantation later on, so that the transplant clock starts later in life, and that there may be a net prolongation of life. That strategy is enticing, unproven, but I think now that we're seeing the types of LVAD outcomes that we're seeing, with 5 and potentially now 10-year outcomes going to be reported within the next few years, these types of strategies, I think, need to be considered. I think we need to make significant changes to the allocation policies that allow these strategies to be utilized and individualized for each of our patients. Thank you.
That's an excellent case. I did want to move into some of these additional questions that have been coming through, and please feel free to add more questions. We have them coming through in real time, so we'll get through as many of these as we have over the next 10 to 15 minutes. We have one question about how many patients with a durable LVAD decline a transplant when it becomes available. I think that's a very interesting question, and of course, hard for us to characterize. You know, as a surgeon, I typically am seeing these patients after in clinic as part of their preoperative workup, or in the hospital as part of their pre-transplant listing workup, after they've already had a conversation with the heart failure cardiologist and team that's been following them long term. So more often than not, when I see those patients, they have already been pre-screened, so it's hard for me to give an anecdotal commentary about that. However, I do have several patients who did have driveline infections, not that were being managed fine with intermittent antibiotics, and then with dressing changes, who would get referred to me because the heart failure team wanted to have a plan should the infection progress. And I can say, anecdotally, I'd say 20% of those patients told me they didn't even want consideration for transplant listing because they had a good quality of life and they didn't want the risk of another heart surgery. Dr. Pagani, did you have any additional comments about that?
No, there seems to be another a question in there. The idea of net prolongation is very attractive and beneficial to patients. And the question is, but it may come with some additional increased risk of rejection due to prior sensitization event, complications from LVAD, which may lead to losing the option for transplant for some patients. And finally, getting an LVAD will put these patients at status 4. That's correct, but one has to consider that there are events that happen on, if a 28-year-old, let's just take that patient, a 28-year-old could get a transplant right away, but there are events that can occur with a transplant that could prevent subsequent transplants. There are, the types of complications, cancer can all develop, both blood and solid organ cancers can develop. Significant organ injury related to diabetes that develops as a consequence, hypertension, all these can have a consequence on an organ function that could translate over a period of 10 or 15 years into whether a patient is a retransplant candidate. So there, the LVAD does have real concerns with a prolongation strategy. And I said, that's not a proven strategy, but I think something that should be considered and investigated. But transplant in a young person is not a benign, therapy either. And so I think there are pros and cons to each approach that we need to consider. And I think we need to be open to consider each and individualize these to different patients.
Yeah, that's absolutely, completely agree with that. I have another interesting question here that a lot of younger patients have a hard time accepting their heart failure diagnosis, and certainly something we've all encountered. The question is, how do we advocate for a VAD first with a transplant later and get the patient on board? And that's an extremely, as everybody knows, a challenging discussion. And a lot of times it's just simply getting past the acceptance and having an understanding that they have a diagnosis that will actually shorten their life. One of the strategies that I use, and I frankly, I do this with all of my patients, but especially with the younger patients, I think it's an important component of having that conversation. And it's, I like to start with all of my patients and just ask them, before they got sick, what was their bucket list, if they had a bucket list, and ask them to list a few things that are on their bucket list. And after their diagnosis, what are the top 3 things from that bucket list that are still on their bucket list? And then I ask them, what brings you the most joy in life? Is it, going to the ocean, going surfing? Is it being with family? Is it your son's birthday? You know, we go through that exercise of really defining what brings the patient joy. And then we follow that with me just asking them how long they want to live. If they could make their own choice, how long do you want to live? And it does take a lot of time. I don't want to deny that. But it's really such an amazing journey to have that conversation with a patient. And sometimes with these younger patients, I do this in series, outline them and kind of give them homework, if you will, and have a follow-up meeting with them. Because it's really important when I talk to these patients that we're aligning what their goals in life are with the best therapy and strategy to get them to that goal. Obviously, a patient who wants to swim the English Channel, I'm not going to say they should get an LVAD, because if they love swimming that much, they're going to be very unhappy and their quality of life is going to be very poor with an LVAD. But if that same person said, I would rather live 20 more years and give up swimming, then that's an opportunity to have that conversation.
We seem to have a few more questions coming in, and this is great. There is a comment regarding patients' desire to move from LVAD to heart transplant is based on the delivery of information to the patient. My experience is transplant is always delivered as a superior to LVAD, and therefore a patient wants transplants even if they are doing well with LVAD. The narrative needs to change in the delivery of information. Well, one of the important pieces of information that is excluded when we talk about transplant is the outcomes that occur from the point of listing to the point of transplant. And as I mentioned before, this creates an immortal time bias. And recently, Tom Cassino from the University of Michigan had a nice paper published in the Journal of Heart and Lung Transplantation on the impact of listing events, and looked at just survival from the point of listing 2 years. And the point of survival was very similar to a durable LVAD. And so, one, I think, has to be honest in the presentation of all information to patients. Some patients may choose LVAD, and some patients and many people feel LVAD is a transplant is superior to LVAD for a number of reasons. But there are, growing numbers of people who feel that the therapy offers an important benefit. And I think what we need to do is not look at them as competing technologies or competing therapies. I think what happens when we look at them as competing therapies, we suffer because we don't offer we don't offer LVAD as a therapy, even to patients who are not transplant candidates, because we just feel it's an inferior therapy, and we're doing, I think, an injustice to those patients. So I think we can present information in an honest fashion and complete fashion to our patients, and really have them make an important decision, with our assistance. And I think we'll be able to offer LVAD therapy to more people who really feel it's beneficial to them.
So we have another question about elaborating on the benefits of less invasive approach on subsequent heart transplantation. So I can speak to that directly just because I do almost all of my LVADs through a bilateral thoracotomy or an upper hemisternotomy if necessary with a left thoracotomy approach. And there was actually a presentation at ASIO last year on some early data with that experience. And what we have found is that the actual sternal reentry is much easier, particularly if they didn't have a previous sternotomy prior to their LVAD going in, of course. So if it is a first-time sternotomy for the patient, it actually is like doing a true first-time sternotomy, never having done surgery. The pericardium is intact. The LVAD is not, the outflow graft is not against the sternum, and the right heart is protected. So it's definitely safer from that perspective. In our very small single center series, we did also see reduced blood product transfusion at that time, shorter cardiopulmonary bypass time. We were able to complete all of our dissections almost in their entirety before going on the heart-lung machine, which was excellent. And confers obvious benefits of, the risks of vasoplasia and additional blood product utilization. And then we also found that the patients were recovering faster. Again, this is a very limited data set, so we need longer term data, but they did get extubated faster, moved out of the ICU faster, and had an earlier discharge as well. So we have another question here, Dr. Pagani. Is there any data of the percent of bridge to transplant LVADs who got a heart transplant? So, and that's in the context of increased allosensitization.
Yes, that data is probably in the UNOS report, in the most recent UNOS report. And I could, I don't have it at hand, the number off hand, but I don't think it's any substantially different than a non-LVAD patient.
Yeah, I know. As we mentioned earlier, 14% of patients listed status 4 underwent transplant, but I don't have that figure broken down by VAD alone. We're getting another question in here, or a statement, actually, it looks like. So there is a comment here that a lot of patients end up with an infection after a VAD, and there's concern that they would not get a transplant in a timely fashion, even with the proposed UNOS changes. And then further concern that some of these patients will end up missing their window to get a transplant, or get a transplant after the infection gets extensive, ultimately affecting or reducing their transplant outcomes. And I think that's a very fair concern. Sorry, Dr. Pagani, did you want to go ahead?
No, go ahead, Kate. I'll comment after you're finished.
Yeah, I think it's a very fair concern that patients do end up with an infection from their LVAD. Again, we don't have great data to say what a driveline infection means for their long-term survival, or how well they do or won't do after their transplant. Certainly, having an infection going into a transplant is that your outcomes aren't as great as someone who's never had an infection before. But the data that we have right now in this modern era and the post-2018 allocation changes, and some of the data that I shared today with these DCD transplants after an LVAD going into a transplant, the survival is really excellent. And and again, I can speak from experience, and as and it's just anecdotal data, but the patients who we list status 4 with an LVAD, if they ultimately have progression of their infection, our common strategy is to bring them into the hospital, make sure that we're controlling that infection very aggressively to improve their perioperative outcomes, and also increase their listing to status 3, or sometimes write and try to get a status 2 exception if there's a major concern that this is going to progress and become something that could be life-limiting for the patient. So I think there are ways to get the patient through this, and also to not miss their window. And then there's also the data that supports that patients who have an LVAD first do actually do very well with the transplant, because they haven't spent that previous amount of time with end organ dysfunction and decreased cardiac output. Dr. Pagani, did you have anything else to add?
Well, I think you raised I think you raised an important issue. It is a concern. It is probably the biggest concern that we have with LVADs. I would clarify a lot in what, it's really important that we clarify what we mean by a lot of patients. Those numbers, don't represent the majority of patients by all. They represent, a minority of the patients. And I think what that does, it brings up one issue. One, I think it really attests to, we need to keep innovating the technology. Every time new technology has come into the field, we've made huge strides in patient outcomes. So I think this is an Achilles heel of the therapy, and we need to address this with newer technology. Two, I think this is similar to what we did with the ARES trial, where we improved patient management through a really rigorous approach. We could do this with this problem of driveline infections because there is significant intercenter variability with driveline infections. So I think it's an issue that's of concern. It does, in fact, impact transplant status, but I think it's addressable through better management, and we just keep having to press for better technology.
All right, it looks like we are at the hour mark. So I want to thank everybody for joining our webinar today, and really exciting time in our field. So thank you all for coming, and thank you to Abbott for this opportunity.